All right, good morning, everybody. Thank you for joining us for the Childhood Lead Poisoning Prevention Programs webinar. This is the first of two. We also have a wonderful presentation for you at 1 p.m. and we hope you join us there. So sorry about the confusion with those links. We have one set of links for the producer, me, and our presenter, Dr. Mary Jean Brown. And then for everyone who's attending the presentation, there is a public attendee link. So hopefully everyone was able to copy and paste that into their browser. So if you know somebody who's trying to get on, make sure they're using the public attendee link. Copy and paste that into their browser, and they should be able to join us through the right way. We just want you guys to enjoy this presentation the way it was meant to be heard. Anyway, my name is Morgan Ash. I'm with the communications team here at the Houston Health Department. We're so excited to introduce our subject matter expert. Her name is Dr. Mary Jean Brown, and I will let her say hello to you and kind of introduce herself.
Good morning, everyone. I'm delighted to share International Lead Poisoning Prevention Week with you. I should tell you a little bit about myself. I'm a nurse by training. I have a doctoral degree in maternal child health. I've been in the lead poisoning prevention business it'll be 40 years in January, and I've served in all levels of government, foundations, and visiting nurse agencies, as well as being chief of the Healthy Homes and Lead Poisoning Prevention Branch at CDC for 13 and a half years. I now am at the Harvard Chan School of Public Health, where I teach courses in applied public health. So today I'd like to talk about the challenges that we're going to face over the next decade or so. We need to implement and sustain policies that will respond to childhood lead exposure, given that we're having decreases in blood lead levels over time. Thank goodness. That's a good thing. So in the U.S. today, less than 1% of children 1 to 5 years old have blood lead levels greater than or equal to 5. We want that to be no children, right, with blood lead levels greater than 5. And I think that we're looking toward having no detectable lead as our ultimate goal for children's blood lead levels. Now, less than 1% in the U.S. as a whole, but that's not true everywhere. So, for example, 1% of children 1 to 5 years old have blood lead levels greater than or equal to 5. We want that to be no children. Right? I don't know what's going on, and I think that we're looking toward having no detectable lead as our ultimate goal for children's blood lead levels. Now, less than 1% in the whole country, but in many places, there are many more children with high blood lead levels. So these two things we have to hold in our mind at the same time. Blood lead levels are going down, but there are identifiable neighborhoods, cities, subpopulations where the children have not benefited as much from this decrease in blood lead levels. So for example, in Chicago, about 7% of children 1 to 5 have blood lead levels 5 and above. Next slide. What about Houston? Well, in Texas, counties reported 0 to 14% of children had blood lead levels 5 or higher, with a state average of 1.4%. So it was over 4,000 children in Houston who had, it was over 4,000 children in Texas who had high blood lead levels. In the city of Houston, where there are 176,000 children, or 7.5% of the total population under the age of 5, the surveillance data, the data that comes into the local health department, indicated that about 58,000 children were screened, which is about 28%. And of those screened, 605, or about 1%, had blood lead levels greater than or equal to 5. Now, these next two bullets may be an indication that some children are being missed. I mean, a screening rate of 28% is not bad, but it's not great either. So about 20% of Houston residents live below the poverty level. That is a very good indicator that children have high blood lead levels. And in addition, Houston has high rates of Black and brown people without health insurance. that's a good marker for poverty. So if you have poverty, you probably have children who are being exposed to lead but are not being identified. So these are the 6 questions we're going to talk about today. What I'm going to try to do is I'm going to try to introduce the topic, like what is the purpose of a lead reference value, and then I'll pause. And I would welcome comments in the chat, or if people want to raise their hands, and we'll wait about 5 minutes and see if there are comments or questions related to these questions. Next slide, please. I think that one of the most important things to understand that a reference value is not a biological threshold. It's not a level that's safe, below which it's safe. It's not an effect level. We use reference values for toxic exposures, including lead, where no safe level has been identified, which is the case with children. And we can't find a safe blood lead level, where no child would have a bad outcome. And we certainly have never had the kind of 100% safe, range around of such a value. So the blood lead reference value is also not synonymous with a blood lead level at which intervention is required or known to be effective. Unfortunately, because of the pathophysiology of lead, the fact that it's stored in soft tissue and bone, and it's an integrated time average of both lead that's been stored and lead that's being ingested. Even when you remove the source of lead, blood lead levels can remain elevated for months to years, depending on how high the blood lead level is. So the selection of any blood lead level is a trigger for action or inaction at an individual or child or community level will be primarily dependent upon the availability of effective remediation approaches and the financial means to accomplish them, and to some degree related analytic considerations. Next slide, please. Okay. So historically, the reference value has been used to guide clinical and public health interventions for individual children. I'm going to argue that for several reasons, adopting the new reference value to guide clinical and public health management puts practitioners in an untenable position. First, because the adverse impacts of blood lead levels in this range are subtle, and although clearly identified at population levels, they are not predictive for individual children. So if I have a classroom of kindergartners, and you tell me that everybody in classroom A had a blood lead level greater than or equal to 5, when he or she was 2, and you tell me that no one in class B had a blood lead level greater than equal to 5 at 2 years old, I can tell you the kids in classroom B will be better off academically than the kids on average than the kids in classroom A. What I can't tell you is that an individual child like Susie in classroom A, I can't tell you that Susie's not going to go to the University of Texas or to, Vanderbilt College. I can only tell you that on average, this group of children. Now that's important because there's something called, if you think that a child is not going to be able to perform, or somebody says to the mom, well, you can't expect that much from Bobby because he had a high blood level, even if that blood level is having minimal or no effects on that child, if his mother looks at him and says, well, Bobby's not like everybody, pretty soon Bobby isn't like everybody, and it's not necessarily the lead that's caused that. So we want to be very, very careful about what we tell parents that could interfere with their expectations of their child. The second reason is the recommended interventions have not been shown to reduce blood lead levels once they are elevated. So I've done 3 or 4 studies. There's been a ton of literature done on various different kinds of interventions, environmental ones, nutrition ones, even at blood lead levels less than 45, treatment with chelation therapy. None of these have changed the outcome for the children. So I've come to think that maybe we chose the wrong outcome measure because of the pathophysiology and the storage of lead in other tissues in the body. Maybe rather than saying, I'm going to go in and I'm going to fix up this house or I'm going to fix up this yard for this child and his blood level is going to go down, maybe what we should have done is see if we can interrupt the trajectory of blood levels. So if we have 1,000 children with blood levels greater than or equal to 5, and we do the interventions to their environments and improve their nutrition and all the other things that you guys do every day, does that prevent them from going up? It makes sense that that's the case, but that's never really been designated. And then finally, another reason to be careful about using the reference value as a threshold for intervention is that the clinical laboratory and office-based blood lead testing devices are not required to quantify blood lead levels less than 4 micrograms per deciliter. In many cases, cannot reliably test for low blood lead levels. So you can have a child and you get one lead test on the kid and it's 5, right? So even if the analytic, even if the instrumentation that's doing the blood lead test is very, very good, a 5 microgram per deciliter test could be a 3 or it could be a 7, right? So it's in a plus or minus 2 range. If it's a plus or minus 4 range, it could be a 1 or it could be a 9. So basing a diagnosis with understanding these 3 points makes it very, very difficult to come up with a level that's going to be an intervention level at these low blood lead levels. Next slide, please. Okay, so here's the analytic methods that are being used for blood lead testing. You know, we have lowered the level of concern or the definition of lead poisoning from about 60 micrograms per deciliter in 1965 to 5 micrograms per deciliter in 2012. And in the pictures here, you can see the different kinds of blood we can use, and you can also see some of the different instruments. So no one is using flame atomic absorption anymore or Delft's cups. Many clinical laboratories use graphite furnace atomic absorption. That's what you see typically in a clinic, a large clinic or a pediatric hospital. But some places, research organizations and people that are doing biomonitoring are using ICP mass spec. The ICP mass spec instrument, which is at the bottom of the right hand of this slide, it's really expensive, and you have to have a highly trained staff in order to be able to do it. And you can see that as we're looking at this change in instrumentation over time, you also see that the geometric mean blood lead level of children has been reduced. So back in the day when I started, the geometric mean blood lead level of children in the United States was 15 micrograms per deciliter. So the Delft's cup and some of the other older instruments could reliably test that, could get you close to 15. By 2005, the mean was 1.5 micrograms per deciliter, and today it's probably close to 0.8, maybe a little bit less micrograms per deciliter. So that's the other reason that the analytic methods have had to become more precise. So I argue that we should be using the reference value as a benchmark, okay? So rather than using the reference value, which is based on the 97.5 percentile of blood lead levels for children in the United States, and it's very accessible because the NHANES data is released in 2-year waves every 2 years, at least until recently. So if we use this reference value, We understand it to be the top 2.5% of blood lead levels for children. I mean, it's a statistic, right? It's not a diagnosis, but it does tell us whether or not we can use it as, are we going in the right direction? Are we reducing blood lead levels for children overall in the United States? Are we having are our laws and policies having an impact? It's very important that we update and report the reference value on a regular basis because it is essential to being able to measure our population success of our work. Now, the 2017-2018 and Haynes data has not been released to the public because of privacy concerns, but we know that for the first time since the measurements were used, the 97.5 percentile has not gone down. So in 2015 and 2016, the reference value was 3.5 micrograms per deciliter, and in 2017 and 18, it was still 3.5 micrograms per deciliter. I don't think we have a real good understanding of why that is. There are many hypotheses, but it's going to take us a little bit more time to figure it out. Okay, so I'm going to pause here and see if there is anything in the chat. Okay, so the next question I want to think about is how can we best integrate primary prevention into our current work? Because clearly, if there's no safe blood lead level that's known, and if we can't reduce blood lead levels quickly once they're elevated, then the best thing we can do is prevent the exposure in the first place, right? So how can we do that and maintain the current work that you all are doing every day on the behalf of individual? So you have to think about it like, okay, when I do something for an individual, how do I also get a population impact from that? It's the conversation the country is having about immunizations, right now. Are you immunized for yourself? Or are you immunized for your community? So let's think about how we could think about that with lead. Next slide, please. So a nationwide primary prevention policy would ensure that no children in the United States live or spend significant time in their homes, buildings, or other environments with lead exposure. One way to do that and make that a component of your daily work is that one way to do that that we can do that is to think about, if you go in and you are doing an environmental assessment or risk assessment in a housing unit, and there's more than one house, there's more than one family, right? So it's a multifamily unit. Pretty clear that if there are no children in the other units, there will be, because that's how neighborhoods tend to be. They're kids living in very close proximity to each other. And even if their child, maybe that child has never been tested, so that's why he doesn't have a high blood lead level. But you know that if there's lead hazards in unit number 1, there's going to be lead hazards most likely in units number 2 through 10 or whatever it is. So once a child has been identified in a multifamily property, that should be a trigger for the whole building being inspected and brought into compliance. In the exterior, the common areas, you want to inspect all the units in the common area. And I know that Houston does not have the a regulation that would support this. So for those people who are not working for the city government or may have access to decision makers, I mean, that's really a good first step, is to say that if a house has a child, a house or a building, a multifamily building only gets one chance, right? Once you have one kid with a high blood lead level in your building, you got to take care of the whole building. And then another thing that you can do is to establish a memorandum of understanding with your code enforcement department so that you can inspect housing with multiple code violations. So this is a real picture of a real house that has a real child with lead poisoning in it. And I'm going to ask you, do you think that lead paint hazards are the only hazard in that house? just from looking at it on the outside, right? So it's very important that these we call them multiple offenders have to really make sure their whole house is safe and sanitary. Okay, another way of addressing primary prevention in your practice is to establish data sharing links with housing assistance programs. So sometimes it's not as likely as it used to be, but if you share addresses, you don't have to give them test results, you don't have to give them the child's name, you don't even have to give them the unit number. You just have to give the housing agency a list of addresses where there have been children with high blood lead levels, and see how many of those children families are receiving a subsidy. It used to be called Section 8, now it's called Housing Choice, or living in publicly owned housing. There are very strict requirements for the property owners of those kinds of buildings, and the Housing Authority and the Department of Housing and Urban Development can help you figure out how to bring those into compliance, and they usually like to do it. Then the next thing you can do is map your data to identify areas or populations where the risk for lead exposure is disproportionate, and then work with and then provide these resources to the decision makers. So I'm not familiar enough to know whether Houston has calls their city government people's counselors. Many places do, but if you give a map of the city of Houston and it has, no children, children are being tested in this area, nobody's over 5, and children are being tested in this area and half of them are over 5, well, the counselor for this neighborhood is going to wonder why his neighborhood is not like that other neighborhood. And it's very impactful, and they get it really, really quickly. And then finally, we need to work with refugee health programs and other community-based organizations that are serving new arrivals. So, of course, you all know about the Mexican pottery and some of the other things that come in from Mexico, but we are going to be resettling tens of thousands of Afghans over the course of the next year. And I don't know what they use that have lead in it, but if history is any indication, there's going to be something. It happens every single time. So we've seen the Mexican pottery, we've seen the Ayurvedic medicines coming from India. So these new arrivals under the refugee health program, they have to be tested before they come in country, and then if they're 6 or under, once they're here after 6 months. So you can find out if these children do have high blood lead levels. And the other thing is that in many cases, the new arrivals will live in neighborhoods that have people from their home countries who are living there, who are immigrants, but they are not refugees. And so you'll know that there's a problem in that community, in that ethnic group, and all of the people of that ethnic group are probably being overexposed. Okay, so now I'm going to stop, and I'm going to take. There's a couple comments. The first one is, we know that elevated blood lead levels usually have no symptoms, but can you explain how IQ is impacted even at low levels? Yeah, so I didn't put that slide in this presentation, but we now have, using MRIs, functional MRIs, we have been able to look at what happens to the brains of people who had elevated blood lead levels in childhood. And what we find is there's been a loss of neurons, and a loss of neurons in the cerebral cortex and in some of the areas across the top of your brain and in the back. And the striking thing is, these are the areas where the behavior or the academic issue is likely to be. So if something happens to your frontal cortex, it interferes with your ability to for impulse control. It interferes with your judgment. And that's one of the reasons why children who with high blood levels have attention deficit disorder, and also they don't have much impulse control and are often, as a result, involved with the juvenile justice system before they graduate from high school. Another interesting thing is that, you know, you're pretty much hardwired to learn how to talk. Even children who are profoundly mentally retarded or mentally disabled can make their wishes known, right? I mean, there are people that can't, but a lot of people that have very low IQ can still say, you know, I'm hungry, I'm thirsty, I'm cold, right? You are not hardwired to learn how to read. You think about it for a minute. When you learn how to read, you got to take a symbol, right? A letter. You got to put it together in a word. You got to link that word to an object or an action, right? So a tree or running. And all of this takes integration from several different parts of your brain. And if those parts are not working well together, learning how to read can be very, very difficult. So that's just two ways. Now, this data is only about, we've only been doing this for like 10 years. We've known that lead caused these kinds of issues for thousands of years, but because we have these MRIs, we're now being able to pinpoint what's going on in the brain. So thank you for that question. The CDC LEAPAC committee has recommended 3.5 micrograms per deciliter. Do you see this being implemented? I'm not sure. I have, the last time I looked at this, I knew that they adopted 3.5 micrograms per deciliter as the reference value, because as I said, it's a statistic. It's not, you know, it's just there. Of course it's 3.5 if that's what the NHANES data says. But I haven't seen anything where they said what you're supposed to do at 3.5. So I and others like me are arguing very strenuously in whatever forum we can that we not use this as an intervention level, that we use it as a way of guiding prevention policies, that we understand that in neighborhoods where lots of kids have blood levels 3.5 micrograms per deciliter or higher, we need to go in and we need to do population-based stuff. We need to do widespread remediation for these neighborhoods, because otherwise we're gonna miss them. What are the ramifications being on programs if it is implemented? Well, one ramification is that your caseloads are going to go up, not by 1% or 10%, but they're going to more than double. And in Massachusetts, it went up over 100%. So you will continue to triage based on blood level, but you're never going to get ahead of it unless you begin to adopt primary prevention strategies into your daily work. So think of a child with a blood level of 3.5 or 5 or whatever you're using as your trigger for interventions. Think of him as a signal that tells you there's something wrong with that environment, and he's probably not the only person that's being exposed. So let's clean up the immediate environment, the building, the soil, whatever the sources are. Another question is, what do you see the ramifications being on programs? No. What ages should we test for refugees? So the refugee health program is required to test children up to the age of 16. And that's because a child is defined by the High Commission on Refugees as being under 16. So they're all tested coming in. Now, I will say that age in the United States, age really does predict high blood levels. So we see blood levels peaking between 18 and 24 months in children. It's not true for in many other countries because the ambient lead contamination is so high and there's lead in so many things. So we gotta So under the refugee health program, families are eligible for Medicaid at least for the first 6 months that they're here, and they are required to be tested at least once before they turn 6. Okay, Ash, you lost my presentation. It's gone again. Oh, there's back. Not quite, but almost. Okay, so can I speak on the importance of screening pregnant women for lead poisoning and how pica poses a risk? Can I put that question in the parking lot because it's a long discussion? Ash, can we come back to that if you have some way of saving that? And then is there research on how lead affects children with autism? If there is, I'm not the person that's most familiar with it. I know that the National Toxic Program has said that lead causes attention deficit disorder. They never use the word cause lightly, but I haven't seen anybody relating it to autism. We do know that children who have intellectual disabilities tend to stay in the mouthing stage, like they put things, non-food items into their mouths much longer period of time than other children. So I would say that children with autism should be tested periodically for lead. I'm not sure what the effects would be, but I can't imagine they'd be good. Oh, at what point is it decided that elevated blood lead levels require chelation therapy? So there's no evidence that chelation therapy, let me start this way. Chelation therapy is a life-saving medication. So we know that chelation therapy can reduce the chances that children will die. So in Nigeria, in 2010, I guess, was a huge outbreak. And before we got the chelating agents into the villages, the mortality rate in the hospitals was about 47%. 2 weeks after we were able to get the chelating agents into the field hospitals, that mortality rate was down to about 0.5%. So I want to make sure everybody understands it really does work. Unfortunately, it doesn't do anything for blood lead levels less than 45 micrograms per deciliter. So it's really important. Okay, now, but because we're looking at less than, the precision on the analytical instrument is not so good that you can tell if a 44 is not a 45, right? There also may be times that a pediatrician looking at an individual child will say, geez, I don't know what's going on here. They cleaned up your environment. You've been on iron forever. Your blood lead level is still 42. And he or she may decide to give this child chelation therapy just to give him a little bit of a push to get some of the lead out of its body. And I think that that's an individual requirement, individual clinical judgment, and I think that the insurance company should pay for it. But it's very important in your daily work when you're seeing families that you make sure that families understand that chelating agents have some consequences, and so they should not go to the internet and order chelating suppositories or other kinds of chelating medications and give them to their child. The chelating agents are not specific for lead. They take out iron, they take out calcium, they take out all kinds of other essential minerals. So it's not some, and it doesn't do any good. So please make sure they understand that. Okay, so what about lead in water pipes? The infrastructure bill currently before Congress will provide funding to replace lead service lines across the U.S. And you, as public health professionals, should be prepared to participate in this effort. So we think that water contributes about 20% to the average blood lead level in children, but varies widely at the individual level. So children in Flint, Michigan, children's blood lead levels went up by about 4 micrograms per deciliter on average because of the lead in their water. So we know that lead in water and lead water can be contaminated by lead because it's leached from pipes or from interior plumbing. It very seldom is it ever at the lead contaminated water at the wellhead, right? So it's something that is added to added to water as it moves through the system. When they start replacing the water pipes in the town, the public health people really have to be at the table and make sure that the entire length of the service line, that's the that line that goes from the street to your water meter, that whole thing has to be replaced. Now, in most communities, the water authority owns the line to the water meter, but there's a little bit of the line past the water meter, and sometimes a little more than a little bit, that is owned by the property owner. And the property owner may say, okay, well, you can go replace your line, but I'm not going to pay to have my line replaced. That results, when they cut that line, that increases the water lead level concentration a lot. And it can stay up there for quite some time. So the whole thing has to come out. So also understand that service lines are not the only source of lead in water. There's also, up until maybe 2 years ago, brass plumbing fixtures were said to be lead safe, but they were allowed to be 8% lead. So all the anti-corrosion efforts need to be maintained. So they put soda ash or other kinds of chemicals in the water to reduce the pH, to make the water less aggressive. And finally, if there's a change in the water supply, so if instead of using deep wells or the bottom of a large deep lake as the water supply, they start using what's called surface water, which means a creek or a river. Creek or river water is much more aggressive. So if there's lead in the line, it will leach into the water much more quickly. Okay, so I'm going to stop here. I have one question that I can see that says, does chelation have any side effects? Yeah, I think I talked about them a little bit. They're minimal, but no drugs are side effect free. So there are occasionally serious side effects that can come from these chelation drugs, but if the children have some other underlying condition. The pediatric environmental specialty health units, and there's one in every EPA region, 10 regions in the United States, has designated one or more children's hospitals as a center for excellence. And those folks know how to chelate children. They've done it, a lot of times. And so pediatricians or nurse practitioners or others who are out there and have never done never chelated anybody should think about calling the PESHU and talking to their doctor, one of the doctors on the PESHU. Also, there are folks at CDC that can help with that too. Okay, so the fourth question is COVID. So COVID's had a big impact on lead poisoning prevention programs. Many jurisdictions have noticed that lead screening rates decreased by 60 to 75% when you compare screening rates in March to June of 2020 with those from the year before. So this means that healthcare providers and health departments need to both catch up on screening and also may need to prioritize cases for inspections and home visits. Next slide, please. So here are some things that you could think about if you want to, if you have to prioritize cases. I mean, we do this in medicine a lot, and we call it triage. So I reviewed the studies published in PubMed between 2008 and 2019, and the studies conducted prior to 2012, of course, were using a blood lead level of 10 micrograms per deciliter as their threshold of interest. Those conducted from 2012 and later used 5. So, and these studies are summarized in the material at the end of the presentation, but I will not present them. Additional risk factors have also been studied to determine whether they can accurately predict which children are likely to have a subsequent blood level that is higher than their initial value. So there's two things here. Which kids are most at risk to achieve a high blood level, and then which children can you expect will go up? They may have had a low blood level in the past, but now they might go up. The risk factors can be used to prioritize the cases in cases as the blood level threshold is 10, 5, or 3.5. So you're going to have to be able to think about not only whose lead level did you get first, but who needs to see you first. Next slide, please. Children who live in old housing built before 1950. In most places, 90% of the children identified with elevated blood levels live in houses built before 1950. However, those children with blood levels 5 to 9 were slightly less likely to live in such old housing than children who had blood levels 10 or higher. So knowing the age of the housing, not the age of the house, but the age of the housing in the neighborhood is a very powerful predictor of knowing where to go to make sure the kids are being tested. Who gets priority for testing? Self-reported questionnaires are not good predictors of risk. However, there's two questions that actually are. The first is whether or not there's peeling paint in the homes in older neighborhoods. And in homes in older neighborhoods are likely to have 2 to 3, with peeling paint, are likely to have 2 to 3 lead dust hazards in the home. So if you talk to someone and you say, is the paint peeling? And the mom says, oh yeah, it's in pretty bad shape. That's another indication that children in that neighborhood are going to have high blood levels. Recent renovation is also a really very strong predictor of high blood levels. Children living in neighborhoods with high numbers of demolitions of old houses were more likely to have high blood levels. Okay, so if there's extensive, we used to call it urban renewal, gentrification going on in a neighborhood that results in a lot of demolition, that all that lead dust gets into the air and the children can easily breathe it. So we know those neighborhoods, kids in those neighborhoods should be a priority for testing. Living in a poor neighborhood can increase the risk for high blood levels regardless of the average age of the neighborhood's housing. And that one we don't really understand why, but it's true. If it's a poor neighborhood, there's more likely to have high blood levels. One thing might be occupational exposure, but we really don't know. Hispanic ethnicity is also a risk factor for high blood levels regardless of other factors, and some of that is because of importation of adulterated or contaminated products. In census tracts with high percentage of African American, blood levels are on average 3% higher than in other census tracts in the same city. Children with blood levels 5 to 9 micrograms per deciliter, however, are more likely to be white compared to those with levels greater than or equal to 10. So there are some racial and ethnic differences going on here which can also help prioritize screening. Next slide, please. I also summarized some studies by for risk factors for increasing blood levels. So if you have a child who had a high blood level during a cold weather month, we know that blood levels increase during warm weather. We don't know why, but we know that they do. So that child with a high blood level, and say at a 4 in February, is likely to come back in July with a higher blood level. That should give him some priority. In Cleveland, Ohio, they looked at this. They found that children who were most likely to have an increased blood level on a subsequent test were male, African American, less than 24 months at the time of the first test, and had an incomplete immunization status. So that's a couple of giveaways, right? So we know that boys Sometimes they have more freedom, but they also have more, they do more exploration, they put more things in their mouths. We know that African Americans are more likely to have a high blood level. We're mostly because of housing discrimination. We know that if you have a high blood level or a blood level approaching high before you're 2, it's likely that the next blood level is going to be even higher. In Massachusetts, looking at 213 refugee children, we found that that were less than 10, we found that 7% of them had levels greater than 10 6 months later. So people like to think that the refugee children have had their intervention, they've moved from their highly contaminated environment, but they often get into housing that's in poor condition, and their parents are totally innocent of any idea around lead paint, so they don't understand. Most native-born American mothers can tell you there's a reason why their 2-year-old should not chew on the windowsill. But African American or other refugee children, their parents are shocked when you tell them that the paint is poisonous. And I've heard them say, in this country you paint your house with poison. So these children, because they often have nutritional deficits too when they come to the United States, they are very highly at risk for that second test to be elevated. So even if you see the Refugee Health Program gives you their test coming in and it's below 10 or below 5 or whatever you're using, that really doesn't give you, it's not a good predictor of what's going to be the second test. And then among refugee children, those that were more than 10, going to have a second test that's more than 2 micrograms higher than their initial value were those that were tested in cold weather months, came from Kenya, and were less than 2 years old at the time of the initial test. So when you're thinking about COVID's impact on you, the first thing to think about is, what am I going to do with this caseload? Well, how am I going to get all these children that weren't tested last year tested this year? You also have to think about how are you going to protect yourself when you go and do these home visits. These are some recommendations that come from lead programs across the country. The first one, of course, is the PPE for all home visitors. So visitors and inspectors, anybody going into the home should have a kit with masks, gloves, booties, and hand sanitizer. Okay, and they got to have the booties too, because we know if there's peeling paint, there's 2 to 3 dust lead hazards in the house, right? So get your booties. They can't hear me. Be sure you change your gloves and booties before the next visit, before you get in your vehicle. So you can bring lead dust on your shoes or on your clothing into your car, and maybe it won't affect you. But we have had children who were lead poisoned from lead dust brought into cars, brought onto car seats. And so it's very important that you change the booties and the gloves before you get in your car. You need to provide staff with laptops or iPads so they can record the data. And you need to conduct as much work as possible using the phone or laptop if you can. So, call the folks, talk to them what the conditions of the housing are, understand you need to bring a translator, try to get all that stuff done ahead of time. And then when you get there, if it's possible to have the tenant take pictures to give you a really good choice, a really good idea of what's going on in that house in real time, that can help expedite an inspection or a health education visit. You should limit the number of people. Okay, you should limit the number of people in the home at the time of the visit. So you don't want to have mom and the sister-in-law and the lady across the hall and all those people in the house because they're all curious about what you're doing there. You want to limit it as much as possible to one person. And then you should email electronic copies. Whenever possible, use electronic copies of lead inspection results, educational brochures, etc., so that you're always going. You're limiting the number of physical contacts you have with clients. Next slide, please. Okay, so what's going on with the Leadcare instrument? And I think we've been joined today by my colleagues at Meridian Bioscience, and in full disclosure, I provide technical assistance to that company in terms of their instrumentation. Okay, Magellan, the people that make the Leadcare 2 instrument, and the U.S. Food and Drug Administration issued a recall notice concerning the use of Leadcare 2, Leadcare Plus, and Leadcare Ultra. It's called the Leadcare Suite, distributed between October 2020 and June 2021. It was expanded then in August, and the lot numbers that are, of concern are available at this website. So they have a whole list. So children who were tested with the Leadcare 2 test kits were in those lots, and whose results were less than 5 micrograms per deciliter should have another test with a venous sample, and it should be analyzed with an instrument with a higher complexity. So, and it should go to a laboratory rather than being tested in an office. So you can't repeat the test with the Leadcare 2. You need to repeat the test with the graphite furnace, atomic absorption, or with ICP mass spec. So the problem here is that the Leadcare, some of the chemicals and some of the tubes involved and the caps and things involved with Leadcare captured lead out of the blood, so that the test result is falsely low. So it's a false negative. Screening programs, that's the scariest thing, is a false negatives, because it means that you missed it. And that's why CDC has recommended that these children come back to be tested, that the test is done with a venous sample, and that it goes to a laboratory with high complexity instruments. Next slide, please. Priority, of course, is going to be for younger children, those living in high-risk areas or population groups. You can catch these kids as they come back for their annual physical exams. Many children didn't get those exams last year, so there's going to be a lot more of them coming back. And in the meantime, as the FDA and Magellan work to identify the cause and resolve it, another analytic method needs to be in place for all children until the recall is resolved. So Magellan and FDA are working together to identify the cause of the negative results, and the earlier recall, the one before August, was the result of changes in the way the caps are manufactured for the venous tubes that caused the caps to capture or sequester the lead. Once the cause has been determined, Magellan will institute changes that will prevent the false negative tests, and the product will return to market. So, I know some people are very anxious to get the product back because it's made things a lot easier for them. Other people are probably never going to go back to it. This is the last question. Can a case be made to continue to test children? So there are people that are going to tell you, I don't want to test kids anymore. Why don't you guys in the health department go out there and test the environment? So the U.S. Preventative Services Task Force issues reports about the benefits and harms of screening, all kinds of screening, cancer screenings, reports on the costs, benefits, and harms of all kinds of screenings, cancer screenings, TB screenings, and blood level. And they have determined that screening for elevated blood levels the data on these benefits and harms is insufficient to recommend for or against it. That is, in fact, and that's a good thing, because it used to be that they said that they couldn't recommend it. So now they're saying, well, there's not enough data. So, however, I've argued with colleagues that we need to look at this from a public health perspective. So there are certain screening criteria that are used to justify whether or not population-based screening is warranted. And I just kind of took them, and instead of looking at the child, I looked at the whole community. What's happened at a population level rather than what happens at an individual level. So first off, the harms caused by lead exposure are well documented and understood. We've known for thousands of years that lead exposure wasn't good for you. Secondly, blood lead testing is a common procedure and is required by law by many states and by Medicaid. Third, chelation therapy is a life-saving treatment, but does not reverse the damage that has already occurred, which means you need to prevent it. Regional pediatric environmental health specialty units can provide technical assistance. Those are the PESHUs I talked about. And finally, tens of billions of dollars have been estimated to be lost annually in the United States because of reduced cognitive potential and the associated loss of productivity for these children as they grow up. The cost of environmental remediation are more than offset by the cost of lead exposure. So it's billions of dollars per 1 year birth cohorts that's lost, and it's probably $3 billion to make all houses in the United States lead safe. Next slide, please. When you're thinking about this, the ethical principles, the principle of justice argues for screening because of the disparities in the risk for lead poisoning and the lifelong harms that are caused by lead exposure. So under the principle of justice, we should be testing widespread testing to make sure that we can find all of those children who need them, many of whom are more likely to be poor or from minority groups. So screening is beneficent as long as the benefits to others are maximized and the harms to the child being screened are minimized. So testing itself, capillary or venous blood lead testing, really doesn't have a lot of adverse impacts. I mean, the child will cry. I've seen cases where the person drawing the blood was crying, but other than pain at the site, it really is not. It really doesn't have a lot. So the harms are pretty minimized. The benefits to others can be maximized if we use those screening results, especially the high ones, to direct us to areas and populations where the risk for high blood lead levels is disproportionate. So if we could explicitly frame childhood lead poisoning within this public health framework, it would be a novel approach to care, right? Now, I wrote this article with my colleague, Alex Kemper, before COVID. So now this idea that we're doing things to benefit individuals, but also to the wider community, is becoming more talked about, more accepted in public health. And there are lessons here for other childhood preventive services regarding strategies for decreasing disparities and the balance of long-term public health and healthcare expenditures. So there is a reference list in the slide, so if you're interested, you can see that article. Next slide, please. Okay, so there's one question out there. I don't know, Ash, much longer do you want me to go on?
That is completely up to you, Dr. Brown.
Okay, so I'm gonna, and people, please, if you have questions, please put them into the chat. But I'm gonna talk a little bit about screening for pregnant women. So first thing is the screening for pregnant women. So the average blood level of women of childbearing age in the United States is something under 2 micrograms per deciliter, right? Asking obstetricians to test every single patient where the vast majority of them are going to have blood levels that are under 2 micrograms per deciliter, it's just not going to work. You're not going to be successful. I used to say when I was at CDC, I can't make them do that, and neither can anybody else. So what we have to do is think about it. Who are our high-risk populations? Well, in Houston, we know that there are products from Mexico. There's the Mexican pottery, but there's also various kinds of candies and spices that come across the border. Usually they're not in commercial vehicles. They're coming in people's suitcases. So it might make sense for a OBGYN practice, hospital or clinic that serves a lot of Mexican and Mexican American women to do blood lead testing during their pregnancy, as early in pregnancy as possible. And to do that at least until they have sufficient sufficient data to say, this was worthwhile, we caught folks that needed help, or, we haven't seen anybody with a high blood. We've been doing this for 3 years now. We've never seen anybody with a blood level higher than 1.5 micrograms per deciliter. So that's thinking about screening, right? Now, the second problem with screening is that you can chelate women in the first trimester, but most of the chelating agents are teratogens, so they cause birth defects. So it's really only for to save the life of the mother that you would do that, and that has to be handled very, very carefully. I would recommend with the PESHU, with the woman, and with her family to help make that determination about whether or not to do that. For blood levels below those that are life-threatening, you're not going to chelate the woman. You're going to try to identify what the source is, and you're going to reduce the contamination, and that's a good thing. But the blood level may not go down, and even if the blood level of the mother goes down, the blood level of the child might not go down, and the baby might not go down as much. So here you are. You've got a mother, and her child's blood level is 10. Her blood level is 10 micrograms per deciliter. Question is, what do you tell her? Do you tell her that there could be a problem? Do you tell her, so it has to be, you have to, within your own practice setting, would be going through, you need to go through all of these things and think about it. The CDC has a document called Managing Lead in Pregnancy and Lactation. It's available on the website. And I would suggest that you look at that carefully if you're thinking about adopting that. Pica certainly poses a risk for the fetus. So the lead crosses the placenta very, very easily. So, right, lead follows calcium in the body, and the baby is, the baby's absorbing lots of calcium from the mom, and so the lead is coming along with it. If they're eating something, whether or not they have pica is like an unnatural appetite, but they could be, some people have pica for dirt or pica for starch, and people have during pregnancy have been known to have pica for other things, but most of these women are not going to have pica. They're simply going to be exposed to adulterated or contaminated food products or medicines. So take a look for those. And probably if you test a woman early in her pregnancy and she has a high blood level, then you need to work carefully. If you're not the health department, then you need to work carefully with the health department and figure out what the source is and how are you going to resolve it. The document on the CDC's website does have in it letters that physicians or obstetricians or nurse midwives can use to get worker removal protection for women who are pregnant who have blood levels greater than or equal to 10. So take a look at that too. And the companies, if it's under OSHA, the company will have to find a woman a job where there's no lead exposure or let her go home and pay her. So here's, I think, our final question. Is school-based blood lead level testing a successful protocol? If so, why is it not more common? It's not really, because by the time children are 5 or 6 years old, they are absorbing lead at the adult rate through their GI tract. So a 2-year-old, especially if she's iron deficient, probably absorbs as much as 50% of the lead she swallows. A 6-year-old and you and I absorb about 10%. So the absorption rate goes down. The hand-to-mouth behaviors go down, hopefully. And a blood level will also, if your blood level is high at 2, we won't find it when you're 6. You will have repackaged that level that lead into your bones and into your soft tissues and excreted some of it. So we won't find it. So that's why it's not been common. What it has been common is requiring blood lead testing for entry into daycare, childcare facilities, and also kindergarten. Kindergarten's still a little bit late, but it reinforces the idea with folks that this is very important. So thank you very much for the opportunity to talk to you today. I really enjoyed it, and I have to thank Ash for enlivening my PowerPoint presentation. Believe me, it was not anywhere near as colorful as all this when I got done with it. So thank you very much, Ash.
Well, no problem. Thank you so much, Dr. Brown. And I seem to have sort of echo, so sorry about those technical difficulties. We did put the live attendee link in the live Q&A. So if you want to join us at 1 p.m., we hope that goes a lot smoother. So please, click on copy and paste that public audience link in that Q&A for the 1 p.m. session. We hope you join us. Thank you for bearing with us as far as some of the technical difficulties and the wrong links. But I think it ended, obviously I learned a lot coming from a communications background. And so hopefully all of you who are really interested in this subject matter got something great out of it. We are going to be placing the recording on our HHD Houston Health Department YouTube page. And Dr. Brown, is it okay if I share those slides with folks who would like to see them?
Oh, absolutely. Absolutely.
Okay, we'll save those as a PDF, and I'll actually send them over to you if you ever need them. And then And we will follow up with everybody and let everybody know where they can find that recording and where they can find those slides. So if you missed part of it because of the wrong link, you'll be able to watch it all and see it all. So hopefully we'll see all of you at 1 p.m. Y'all have a great rest.
Have a happy rest of International Lead Poisoning Prevention Week.
That and go Astros.
Wow. Bye.